Okay, let me get started so we can have enough time at the end or plenty of time at the end for discussion. I'm Frances Levin, and I'm one of the co-directors of the Chosen Center, which is sponsoring our seminar today. Our seminar is on psychedelic assisted therapies for substance use disorders, a contextual overview. And what's going to be nice about this presentation is Jay Sevelius, who you're going to be hearing about from in a minute, and Heidi Allen are going to be going back and forth and provide an integrated talk. So it's not one and then the other. For that reason, what I'm going to do is I'm going to present both of their bios so you know a little bit about both of them. And then what I'm going to ask people to do is, in as much as possible, let's wait till the end of their presentation, and then we'll have hopefully plenty of time at the end for questions, unless Jay or Heidi want to entertain questions, and that's fine too. But let's see if we can get through the presentation first and then have them talk at the end. So let me first introduce Jay. Jay Sevelius, PhD, is a professor of medical psychology in the Department of Psychiatry at Columbia University Medical Center and a research scientist at New York State Psychiatric Institute and is a licensed clinical psychologist. Dr. Sevelius's NIH-funded research focuses on developing evidence-based interventions to improve mental health, substance use, and HIV outcomes among gender-expansive people in the United States and Brazil, using community-engaged and trauma-informed approaches. Their research on psychedelics focuses on psychedelic-assisted therapy for identity-based trauma, as well as mixed methods for exploring naturalistic use and psychedelic therapy practices. I've known Jay for a number of years now, and it's really wonderful to have her be presenting to us today. Along with Jay is Heidi Allen. Heidi Allen is an MSW PhD and the professor at Columbia University in the School of Social Work and Millman School of Public Health, Department of Health Policy and Management. Dr. Allen studies the impact of social policy such as Medicaid, America's health insurance for the poor, and the therapeutic approval of psychedelic medications on access, health, and mental health and financial well-being. In 2024, Dr. Allen created the Columbia Psychedelic Therapy Training Program, the first comprehensive within-degree psychedelic therapy training program in an academic professional school. Embedded within the advanced clinical practice track of Columbia's MSW program, participants are provided with 120 plus hours of didactic education and 600 hours of clinical training in the psychedelic practicum. In 2026, Columbia School of Social Work will additionally launch a minor in psychedelic therapy. So it's my great pleasure to have both of them here today, and I'll let Dr. Sebelius begin. Thank you, Jay.
Great. Thank you so much, Frances, for that great introduction. We're so excited to be here today. And as Frances mentioned, we're going to be talking about psychedelic assisted therapies for substance use disorder. And we're really providing a contextual overview. So what that means is we're going to be kind of giving the broad picture of what psychedelics look like right now in terms of which psychedelics are commonly studied, what the regulatory landscape looks like in the field of psychedelics right now, some potential mechanisms of action. So how do we think psychedelics work in substance use and mental health treatment, that rationale, what the current state of the clinical evidence is, and some of the challenges in gathering that evidence. We'll talk a good amount about access issues, as that's Heidi's real area of expertise. And then we'll touch a little bit on harm reduction strategies and special considerations. And as Frances said, we'll go through the slides and have plenty of time for questions and answers at the end.
Thank you. Thanks, Jay. So I think it's important to start by defining what we mean by psychedelic, because there are many different definitions. And in the broadest sense, the most generalized definition is from the Greek, and it means mind manifesting. So it's anything that can induce a mystical, spiritual, or visionary experience. And that includes things like ketamine. It could include cannabis. And as we move more specifically, we're typically talking about molecules that impact the 5-HT2A receptor, and those include tryptamines like psilocybin, LSD, DMT, and phenethylamines like mescaline, MDMA. And then the purists will say that the only true psychedelics are the tryptamines like psilocybin, LSD, and DMT. Next slide. Um, we're going to talk a lot about the different compounds and particularly how they relate to substance use disorder. But just to kind of, as a general orientation, you can see that the green colored substances are naturally produced molecules. Like one comes 5-MeO DMT from a toad. Ayahuasca DMT comes from a vine. And then you have psilocybin mushrooms, and then there are the molecules that have been synthesized in the lab, like LSD, ibogaine, actually is a naturally occurring one, and MDMA. They have different histories and they have different uses, but one thing to point out when you're looking at a diagram like this, which is looking at the molecules, is you can look at the difference between psilocin and DMT, and you can see that only the very slightest difference really dramatically changes the experience of the molecule. And we'll come back to that idea soon because we'll talk about what drug companies are doing to patent and create new molecules. Next slide. Each molecule has its kind of own signature experience, and typically this has been measured through the 5D ASC, which is a five-dimensional altered state of consciousness rating scale. And the three main concepts here are self-disintegration, perception, and oceanic boundlessness, which I love that term. And what this graph shows is among 3 or 4 of the common molecules, just the really different ways that the drug is experienced by people, which we believe could have, implications for whether they're effectively used while somebody's in psychotherapy or not. For example, MDMA is a drug that gives people a sense of connection and helps them feel open. LSD has elementary imagery. Ketamine can be disembodying. So just something to keep in mind that the molecules will under maybe the same umbrella, really from a clinical perspective and implementation would be quite different. So another really important thing to start with before we launch into a talk like this is that psychedelics are happening in a lot of different places in a lot of different ways. And so having a conversation about their risks or benefit is very, very contextually dependent. Because each of these contexts bring opportunities. They can be more or less accessible, and they can bring more or less safety. So on the far left, you have the Religious Freedom Restoration Act of 1993, which legalized peyote for use by the Native American Church, and Daime, which is like a form of ayahuasca for the Santo Daime Church. And while those were church has not been super well defined. And, if you were to Google psychedelic church in New York City, you would very quickly find that there are a number of them. And whether or not they are in line with federal law, it's hard to say. What context they're being offered in is hard to say. It has not been overly enforced by the federal government. And so I think that there has been probably some use of that regulatory pathway that maybe would not muster a bar if scrutinized. And then we have efforts to decriminalize psychedelics, particularly this is found around plant psychedelics other than peyote. This has usually been done at the local or state level. This is, reduces or eliminates criminal penalties. Sometimes it just deprioritizes enforcement. But this isn't the same thing as legalized regulated use, which is what we see in the next category, which is we termed wellness. These policies have passed at the state level, and they are, I think of them as adult supervised programs. So they're regulated by the state. The two most famous right now are Oregon and Colorado. Oregon passed their psilocybin bill for adult supervised use in 2020, and it was implemented in 2023. And Colorado passed theirs in 2022. What's unusual about the Colorado model is they recognize that in Oregon, a lot of clinicians were working with psilocybin, which was outside their scope of practice of their license, and put them in kind of a vulnerable legal state. And so what Colorado did, since they came after Oregon, is they created a clinical pathway where people could practice under the scope of their license. They also expanded the number of molecules people could work with. So they also included 5-MeO DMT and theoretically ibogaine. And then we have what we think of as the medical model, which is mostly administered at the federal level. The exception is at the bottom, which I'll mention soon. And this is when FDA approves a drug for an indication. And these have been so far synthesized compounds, not plant compounds. And once FDA approved, they can be used on or off label. And another way that people can access the medical model right now is through clinical trials and research, of which a lot is happening. And then we have New Mexico, which passed a plant-based psilocybin medical program in 2025 through their state legislature, which is interesting because the Oregon and Colorado measures were passed by the ballot. But this is a medical only model. And since then, even this current legislative session, there have been dozens of proposals across the country and different states, and they seem to be following the New Mexico model, where they tend to be focused on medical use, not adult supervised use, and where they tend to be asking for more research. Next slide. But it's important to note that last week, Donald Trump signed in an executive order to expedite the approval and access of psychedelic therapies. It's unclear exactly what this is going to mean, but some things to keep an eye on is one, currently psychedelics have been excluded from right to try laws and expanded access programs for people who've exhausted other treatments. That's not the case in other countries. Like Colorado has a pretty robust compassionate use model right now where people are accessing MDMA, psilocybin, 5-MeO DMT for mental health reasons. But in the United States, the Scheduling 1 status of psychedelics has meant that they have not been widely used, and probably only a couple hundred people have been able to access them. So Donald Trump implied to the FDA that that he wanted to see more compassionate use. Well, drugs who are in late state clinical trials are making their way through the FDA process. The executive order include $50 million, which we suspect is meant to match ibogaine research that was passed in Texas. They had been looking for a $50 million match and unable to secure it from a private manufacturer. And so this is an interesting case of where the government is stepping in to bring that money. It's also asking NIH to disregard the Schedule 1 nature of drugs that are currently under review by the FDA and open up research money. And then it signals to the FDA that they should hasten the process. And that might be by reducing some of these other barriers to funding, but also the possibility of expedited approval. So 3 companies received national vouchers for psychedelics, which means when they submit a packet to the FDA that it's supposed to take months, even less time than breakthrough therapy status, which these substances had before. And then once they pass FDA approval, they will also have to be rescheduled by the DEA. And some states have trigger laws where they themselves have to also reschedule after FDA approval. Next slide. So where are we? And is this, I think people saw that executive order and there was a big, well, wait a minute, is this a good idea? Is this a bad idea? And I think that it depends on your perspective. Psychedelic research is not new. It really started in the 1950s when, like things like LSD were synthesized, when psilocybin was brought back from Oaxaca and synthesized, and they started being used pretty liberally with psychiatric patients and in individual therapy and couples therapy. But the literature at that point was primarily case reports. And what wouldn't be considered rigorous by the standards of today. The Controlled Substance Act that was passed in the 1970s really put a stop to that research, and you can see that it almost completely stopped the publications about psychedelics. And then as MAPS, Rip-Doblin was able to get the first kind of approval for a substance to re-enter into clinical trials, you've seen this increased research over time, and the rigor of the research has been increasing over time. And I think that that's even more so true today than it was 5 years ago. And now, if you were to go to clinicaltrials.gov and type in the word psychedelic, you would see that there are thousands of studies occurring right now. So why should we be excited about psychedelics? And I say excited. I am excited about psychedelics. I don't consider myself a psychedelic evangelist. I think that psychedelics aren't for everybody. I don't think that they're going to lead to net zero trauma like some people have claimed. I think that they are potentially a really good addition to the toolkit that we have currently for treating mental health and substance use disorders. And I just want to name some of the reasons why they might represent an advancement in the field. The first one is if they work, and they don't always work, but if they work right away. So cross clinical trials, if you look at the graphs, you see that at the first measurement point post dosing session, if the response is there, it's there right away. It's usually pretty dramatic. We do have other tools in our toolkit that do that as well. Benzodiazepines are one, antipsychotics are another, but both of those bring problematic side effects. So antipsychotics can have problems about cardiovascular health. And benzodiazepines, of course, are addictive. So this brings in a new opportunity for a treatment that you could see using in an acute setting, like an emergency department or inpatient psychiatric hospital, that might be an advancement over the other two that are currently most often used. The second thing is that they show that so far in the literature they have been shown to be broadly efficacious, I would say around the same efficacy as benzos, SSRIs, or sometimes better. Another reason why they might be, superior to be benzos or antipsychotics or SSRIs is that typically we think of giving people psychedelics once. Many of the clinical trials that are published now are single dose sessions or in a series that happen over a short period of time. We don't really know how long the effect will last, but I think that people are assuming that, the clinical trial results that are showing efficacy to, like 6-week, 12-week endpoints, that is promising, and that probably people will have to have dosing at periodic times, so we don't know how long that might be. But it is different than starting a drug that you might have to take forever. And, the kind of assumption that we've made that psychiatric mental health is a chronic condition and not an acute condition has meant that when people are responsive to drugs like SSRIs, we're often afraid to take them off. And there is some concern that their brain may be, even if they hadn't had a chronic episode of depression, if they had acute episode, that the brain might somehow adapt to the SSRI, and then the person could experience depression when they come off. And so what's nice about psychedelics is there's an off-ramp. If it works quickly, it works right away. If you might need to do it again, if it seems like you have to do it a lot, it might mean moving to something that is more maintenance, like an SSRI. That is also true of the side effects. The side effects tend to happen during the dosing session and maybe 24 to 48 hours later, but it's very rare to have extended side effects. One thing that I think is particularly important about psychedelics compared to benzodiazepines, antipsychotics, or SSRIs is that people describe them as expansive rather than blunting. So they widen individuals' windows of tolerance. They also widen their access to emotions. So they feel more rather than less. And that is something that I think we would all want for ourselves. Another thing is that many people have found the clinical trials to show, to be very profound and meaningful experiences. Even in a country where I think we have slight preference for medicine that is bitter, I think the idea that somebody could have a treatment experience that feels to them, in one study, participants rated as one of the top 5 most important events in their life. Another advantage is that we suspect that it could be an accelerator for therapy. So when therapists accompany people during psychedelic experiences, it tends to produce this very strong therapeutic bond, something that in social work school, we're constantly trying to teach students how to create the therapeutic container, how to create that trust, and how to create that safety for people to be able to do the deep work that they need to do. And it seems like psychedelics are unusually good at creating that container. And then the last thing is that, well, it's being used for specific indications like as for depression or anxiety or substance use disorder. There's evidence of spillover effects into other symptoms, and that even includes physical health. So there are studies that are looking at psychedelics for physical health. But if we think of, and we're going to show a graph later on, but when we think about the overlapping of symptoms across diagnostic conditions, that while you're treating somebody's depression, you may also be treating symptoms of their anxiety. You may also be treating problems that they have with sleep and other things like that.
Great, thanks, Heidi. So now let's talk a little bit about this specific application to the treatment of substance use disorders. So I believe, most of you in this group are well aware of how profound the global burden of substance use disorders is globally. And substance use disorders are one of the most difficult behavioral health conditions to treat because they're not simply disorders of exposure to substances. They're disorders of learning, reward, memory, social context, trauma, coping, meaning. And so for many people, substance use might be initially adaptive, where it's offering relief from pain, it's offering connection, maybe it's improving sleep, numbness, escape. But over time, that same behavior can become organized into a narrowing loop of craving, withdrawal, temporary relief when the substance is used, and then you lose that sensitivity to natural rewards. And that craving and reward system around the substance use becomes incredibly rigid. So that the loop of substance use disorders can be very hard to break because there are biological components, psychological components, relational and environmental cues that need to be addressed at the same time. So Heidi started to talk about sort of the breakdown of how we think about psychedelics. But these are the 6 that are really primarily being looked at right now for substance use disorders. You've got the classic psychedelics, which are the serotonergic psychedelics, psilocybin, LSD, and ayahuasca or DMT. And primarily, those have been used for alcohol use disorder. Tobacco, in the case of psilocybin, has some interesting initial evidence. LSD for alcohol use disorder are some of the oldest studies of psychedelics for substance use disorder. famously, Bill W. from Alcoholics Anonymous conducted one of the first studies on LSD for alcohol use disorder. And ayahuasca and DMT are currently being explored. And then you've got ketamine, ibogaine, and MDMA, which are considered the non-classic psychedelics because they are not primarily 5-HT2A serotonergic psychedelics. And those are also studies are also looking at these substances across several substance use disorders, including opioid use disorder, cocaine. And MDMA is an interesting one because a lot of the studies are looking at the comorbid existence of PTSD and alcohol use disorder and how commonly those co-occur. So the idea is potentially that if MDMA for PTSD shows efficacy, that like Heidi was saying, there may be spillover effects into other things like substance use disorder. And just to acknowledge that this really represents a paradigm shift in addiction medicine. Not to say that psychedelic assisted therapy would ever replace the standard pharmacotherapy that we see is often life-saving for people. It's not to minimize how existing medications for things like opioid use disorder or nicotine dependence have important roles. But psychedelic assisted therapies have re-entered the conversation because they work differently from maintenance pharmacotherapies. So psychedelics could be an additional tool in the toolbox of how we work with substance use disorders, not necessarily meant to replace the maintenance paradigm. So rather than providing a daily administration of a medication that might be stabilizing for someone with substance use disorders, the psychedelic models often attempt to create a time-limited experience of disrupting that loop that we just talked about and increasing psychological flexibility, which then potentially opens a window for intensified therapeutic learning. So it's more likely that under carefully structured conditions, some psychedelic compounds may create a window where these entrenched patterns of substance use are more available for revision. And that's how psychotherapy, social support, recovery practices can really help shape the result of psychedelic assisted therapy.
So we just wanted to quickly go a little bit deeper into how people think that psychedelics work. And this is an evolving science. And so, this slide might look different in 5 years, but so far the thinking is that the person ingests the drug. This leads to a release of neurotransmitters and activation of the receptors, particularly 5-HT2A. And that this changes the way the brain talks to itself and predicts events. So essentially, this reduces kind of our higher order thinking, the very strong narratives that we have. They call it the entropic brain theory or relaxed expectations under psychedelics, the rebus model. But essentially, it allows us strong narratives that we have kind of dissolve, and other information that's below that can rise to the surface and be seen. That can happen through getting new brain connections, what we think of as the psychoplasticity of the brain. There's been work on animal models to suggest that it reopens critical learning periods that are similar to what we have in childhood, like when we're really good at learning about attachment, where we learn about language, where, the time of our life where we're primed to learn very quickly because we need to survive. It also, one thing it can do is it can reduce the limbic activation when you're processing trauma. That's particularly like for MDMA, and open the window of tolerance so that people can, unlike, some exposure therapies, which can be highly aversive for people and have high dropout rates. This reduction in limbic activation can allow people to revisit traumatic experiences in a way where they are resourced to do so, and they can stay with the topic and they don't feel, like panicked and like they need to end therapy. That's part of the increasing the tolerance of difficult emotions. And that ultimately it can change our story and allow us to have emotional breakthroughs. There are people who have reported feeling connection to a larger whole, finding meaning and spirituality. And one area the psychedelic seems to be very promising related to that is end of life care.
So, as Heidi was saying, classic psychedelics act primarily through the serotonin 5-HT2A receptor pathways and appear to alter large-scale brain network dynamics. So this alteration in dynamics seems to point to specifically around information integration and cognitive control, so that this reorganization may allow patients to gain a new perspective on themselves, on their lives, and by escaping rigid thinking patterns. So you'll see these types of images often recreated in scientific presentations because it reflects the recent neuroimaging work that found that psilocybin disrupted functional connectivity across primarily the cortex and subcortex, with especially large effects in the default mode network, and produced persistent decreases in connectivity that lasted weeks. And so the idea is that you have these very rigid connections in place before the psychedelic dose. The acute dose kind of opens up those connections and allows parts of the brain to talk to each other that don't normally, and kind of loosens the rigidity in the associated brain regions. And the integration process, which follows the acute psychedelic dose, is meant to reinforce some of those new neural pathways that become available through the acute psychedelic dosing session.
So there's some really interesting research, currently animal model research, but worth noting, which is this idea of reopening critical periods, what I mentioned a minute or so ago. But what I want to pay you to notice of this particular graphs is that there seems to be a relationship between the duration of the acute experience on the psychedelic and the time that this opening of critical periods occurs. So like for a short acting substance like ketamine, which, can last between 30 minutes and 2 hours, that reopening of the critical learning period is only 48 hours. But a substance like ibogaine, where your ibogaine experience can last 36 to 72 hours, they've found in animal models that the opening of the critical period can last up to 4 weeks. And so just to notice this, because it can give us a clue as we're thinking about how to make embed these in treatment protocols of how can we take advantage of when the brain is most flexible, and when we can help people solidify new learning. And it looks like the period directly after the dosing session, for differing lengths of time, would be that when we would want that to happen.
So I think we are kind of driving home this point, but just to really kind of keep going with this metaphor, is that the molecule itself, the acute psychedelic experience, doesn't necessarily offer this simple causal pathway from brain network desynchronization to substance use recovery. But it does support the metaphor that psychedelics may temporarily loosen rigid patterns. If the brain is usually organized around stable predictions, and like these habitual stories that people may tell themselves, or familiar emotional responses or learning habits, then acute desynchronization of these brain regions may create a state where old associations are less dominant and new behaviors or perspectives can be introduced. So psychologically, so you've got this gear one, neurobiological drivers, you're opening up those critical learning periods. You've got then what we're calling year two, or the psychological mediators, where many participants describe an emotional breakthrough that can happen during the acute psychedelic experience. They describe insight about their lives. They start changing the way they talk or think about themselves. Their acceptance for their situation increases. People often report mystical experiences, which are sometimes referred to as like a feeling of awe at the state of the world or at being alive, or a sense of ego dissolution, where like being at one with all that is. And this can have a spiritual or existential quality to it. And these experiences might matter because, it's not just behaviorally about reducing consumption of a problematic substance, but it's often about helping people really rebuild a life where not using substances becomes meaningful and feels possible and feels socially supported. So gear three is really that behavioral piece where the key word is integration. It's about integrating those insights, integrating those renewed or altered self narratives, and what we're saying really is that just having this flexible state, or the neuroplastic state, isn't enough on its own. It's beneficial, perhaps because you can utilize that critical window that is open to really leverage the learning process to integrate in a positive way those that acute experience. And there really needs to be a lot more research on what the best modalities for integration are, in order to address substance use specifically. But there was a really nice article in a book called Disruptive Pharmacology that looked at psychedelic assisted therapy for substance use disorders. And the neurobiological mechanisms that we've been talking about so far are in green on the left. And then you've got the therapeutic implications in blue on the right. And you can see how researchers and clinicians are starting to think about how we might leverage some of the neurobiological mechanisms that psychedelic assisted therapy offers. Things like alterations in brain network connectivity. Can we, in the integration period after the acute psychedelic experience, leverage some of the evidence-based therapies that we know work with substance use disorder, like contingency management, motivational interviewing, cognitive behavioral therapy, to really help people increase things like their natural reward responsiveness, acceptance and processing of negative emotions. These are things that we already know can work in therapy, but that psychedelics can really offer us kind of a leg up into this window of increased ability to work with our patients. So for the most part, with most psychedelics, the therapy would happen during the integration period after the acute dose rather than during the psychedelic experience itself.
Interestingly enough, though, I just read a study that suggested that the work that's done in preparatory sessions seems to be related to better outcomes than that was done in integration, which I thought was really interesting. Just so that you know what we're talking about when we talk about having a psychedelic experience, it's typically broken into 4 stages. The first is screening, where you make sure that it is medically and socially, emotionally appropriate for the person who is thinking about getting the psychedelic. And I'll say more about that in a minute. And then preparatory sessions, they differ in research trials. So some research trials have done up to 3 preparatory sessions. Some have said we'll do as many as necessary. I think in real clinical practice, it's probably important to do as many as necessary. Some clinical trials have only had 1 to 2 preparatory sessions. Then you have the dosing session, and then all of the protocols have at least 1 integration sessions. Some have multiple ones. Next slide. And just to note that that we're, regardless of how these roll out, I think that there's an assumption that it's going to require a team, and that the client is part of that team. You need a medical provider who's going to do a medication review, a medical assessment, a psychiatric assessment. You need a client who will communicate truthfully and honestly, and give you a good social history. And you need, we believe at least, that you really do need therapists who can do the psychoeducational assessment, assess their current mental health needs and their support system, and help. There's a component to successful psychedelic assisted therapy that I think probably looks a lot like case management as well.
And I mentioned these earlier, but I think it's going to be a really interesting time to be conducting more research in, how our existing evidence-based interventions can help us capitalize on that neuroplastic window. And I'd be really interested to talk more, Heidi, about how preparatory sessions, really might shape the therapeutic outcomes, especially given that the neuroplastic window is opened after the acute psychedelic state, and how we might apply some of these therapies specifically to substance use disorder. And here's some of the theories. Again, this is a really exciting area for research. We don't have a lot of research on, what kind of therapies complement psychedelics or specific psychedelics. We're talking about psychedelics in a very generalized way, but obviously each compound has its own unique fingerprint.
Mm-hmm.
But motivational interviewing, obviously promoting change talk, reducing ambivalence, increasing insight, CBT, perhaps the reduction in amygdala reactivity could allow people to work more effectively with CBT when it triggers negative emotions, enhancing coping skills. Contingency management is something we've looked a lot at in the field of SUDs, and how might we leverage contingency management to kind of rework these like cue reward loops that are really difficult to address in substance use disorders.
So this is a very busy slide. I don't expect you to really be able to read it, but the pink dot in the middle is approval from a psychedelic pharmaceutical company. And you see that the only thing we have in there right now is Spravato, which is a nasally ingested ketamine. But then you see all of these companies moving from phase 3, phase 2, phase 1, and discovery and preclinical. And this is kind of, you can see where the action is around the compounds. You have a lot happening with 5-MeO-DMT, probably because that substance is administered over like 15 minutes. So that has a lot of things that might be really workable into our current system. You see that psilocybin is really far into clinical trials, very near FDA approval. True with the MDMA-like molecules, and you have some LSD molecules in that category too. And then you see ketamine has a bunch of clinical trials that are for different indications other than treatment-resistant depression that are making its way. But over here, you have this huge other category. And what is that? That would be efforts to try to maybe blend molecule experiences together. It could be efforts to try to take away the psychedelic experience from the psychedelic. Can you get the neuroplasticity without having a subjective psychedelic experience? Can you make a molecule less, have less nausea? Can you make it shorter? Can you make it longer? So that's what you see over on that other side. Next slide. But you can see here, this is distributed the same kind of bullseye pattern, but starting with phase 2. You can see for substance use disorder that there's a number of clinical trials in phase 2, like 5-MeO-DMT for opioid use, psilocybin for stimulant addiction, alcohol use disorder, opioid use disorder, ketamine for alcohol use disorder, sublingual DMT for cocaine use disorder. So these are all in phase 2 clinical trials. And then you have some that have moved into phase 3 clinical trials as well. Keep going.
And this is just an overview of a systematic review that looked at clinical trials and randomized control trials conducted from 2013 to 2023, specifically focused on treating substance use disorders. And just to give you kind of a snapshot of the key findings, there were 16 clinical trials. They found that psychedelics like psilocybin and ayahuasca did show promise in reducing alcohol and tobacco dependence. Psilocybin being particularly effective in decreasing cravings and promoting long-term abstinence. And that the improvements were especially significant when they were combined with psychotherapy. But you can see here that there's a lot of variability in terms of the substance, the dosage, their small sample sizes. So our research is still in its early phase, where there's a lot of evidence to show that there's good reason to be looking at psychedelics for substance use disorder, but we still need really rigorous large-scale trials to be able to validate these results and develop consistent protocols. Right now, psilocybin and ketamine are sort of leading the charge with substance use disorder. Like I said, psilocybin particularly effective with alcohol use disorder and tobacco use disorder, ketamine being looked at for opioid, cocaine, and cannabis use disorders. This is just sort of repeating the same idea, but with a heat map where you see that LSD and ibogaine, as well as MDMA, are being looked at for these substance use disorders, in particular, alcohol, tobacco, opioid, and cocaine use disorders. But psilocybin is kind of ahead of the game.
This is my favorite side to show in class, because now we're going to talk for a minute about some of the difficulties with psychedelic research. And obviously, one of the primary difficulties with psychedelics is it's hard to administer anything as a placebo that feels like a psychedelic.
So essentially, this becomes a blinding dilemma, which we've heard a lot about through the, when the FDA was reviewing the application for MDMA for PTSD, blinding was a significant concern because these substances create such profound effects on consciousness. The patients typically know immediately whether or not they got the placebo or the active drug. The therapists often know as well. And so this creates expectancy effects, and it creates a lot of interpretive uncertainty. So is the expectancy bias driving the results, or are there ways that we can design our studies to reduce the expectancy bias? So some of the solutions that researchers are looking at are the use of active placebos like niacin or low-dose stimulants. I believe Adderall was one of the placebos in one of the studies. Factorial designs could be really promising. If we have large enough sample sizes in our clinical trials, we might be able to parse out some of the objective effects of the drug and the psychotherapy. And they're also looking at potential biological outcome measures.
But this is overall what I would say is the clinical picture of psychedelics. We have some very well done design studies. There's a lot of reason to be excited. There's a lot of hope. But we have a really long way to go. And this work needs to be done carefully, particularly, I think, when it comes to thinking about substance use disorder. Nobody wants to see a repeat of the opioid epidemic, where people thought that they were solving one problem, but they created an even bigger problem. And I think everybody is well aware of the need to, despite the executive order, but to continue to do really rigorous science to understand how these molecules work, who they should be, who should work with them, and how to make them as efficacious as possible and reduce risk. But this is something that makes me feel hopeful. This is a diagram, like a heat. I don't know what the exact term is. Intercorrelation map of the DSM-5 chapters. And so this shows within and across chapter overlap of symptoms. There's been some talk lately about, how psychedelics kind of challenge the DSM-5 paradigm of trying to find an indication and match a treatment, and suggestions that maybe we should move towards more functional impairment measures. So measuring symptoms, and seeing if psychedelics can work to do symptom reduction. One thing I like about that is that would mean a lot less millions, billions of dollars put into clinical trials to, try to get on-label use, which comes with insurance coverage for every single molecule, for every single indication. The other thing I like about it is that one thing about the DSM-5 is that it's a threshold measure. So you either meet criteria or you don't meet criteria. And if you have a molecule that is determined to be low risk, like perhaps psilocybin, why would you want to wait until somebody crosses over into threshold impairment before trying something that could improve their life? Next slide. So I'm going to run through the next slides really quickly so that we have lots of time for discussion. But everybody probably in this webinar knows that mental health and substance use disorder are one of the leading causes of disease burden in the United States. More so than many of the things that receive a lot of money and a lot of attention. Next slide. And yet it's really hard for people to access. One of the number one reasons for people not accessing mental health services is they couldn't afford it, which is closely related to the last one, which is insurance doesn't pay enough for providers to accept their coverage. And then you have the one in the middle, which is concerns about being committed or having to take medicine. So many people do fear the on-ramp of having to say, I'm going to take a SSRI every day until the day that I die. And so it's really important as we think about psychedelic assisted therapy that we really attend to issues of cost and access. Next slide. And at the beginning, when MDMA research started coming out, we thought the MDMA was going to be the first psychedelic to have approval. One of their early 2020 papers priced it out at like $7,000. The next paper that came out after phase 3A trial priced it at $11,000. When it came out at 2023, phase B, it was $23,000. When ICER did their estimate in 2024, they estimated it was $28,000. Next slide. So what are the costs with that? Well, that's really related to the intensive therapy that Lykos had embedded into their model. So it was person hours. Two therapists were in the room at all times. They had 30 hours of a doctor on call. They had 40 plus hours of therapy with those two therapists. And that led to a base cost of $20,500 following that protocol, not including the cost of the medication itself. Next slide. How does that compare to other treatments? Well, it's more expensive. But it's not entirely out of line if you consider that 12 months of a weekly DBT group in therapy might be $20,800, but it's certainly such that you would want to ensure that the treatment is both offering something that existing treatments currently don't, that it's better for the patient than current treatments, and that it endures. Next slide. And so there's a lot of unknowns that I think are going to impact whether or not people have access to this expensive treatment. Some of them will be determined by the FDA when they establish the rules. They may require that there be an MDM on call. They may require that there's 2 licensed therapists in the room. They may require that those therapists have taken certain exams or gotten certain certifications. We don't yet know what the training and supervision requirements will be. I personally hope that we will just let people practice under the scope of their license and then make training for psychedelic therapy as easy and as accessible as possible. But there have been a lot of efforts to create organizations that would profit from certifying both instructional organizations and clinicians. If it is very expensive, it's hard to know whether small private practices will be able to offer it. And we don't know what therapies will become evidence-based within the field of psychedelic assisted therapy. Next slide. When I'm teaching my class, I try to teach students to think about balancing access and quality. And while it's not entirely a zero-sum game, there are certainly things that can increase quality and lower access. And those are things like having a parallel licensing structure. So if you require a social worker to go through everything it takes to become a licensed clinical social worker, and then you say, and you have to do 120 hours in psychedelic assisted therapy education, and you need 40 hours where you're supervised by somebody who is a clinical supervisor in psychedelic assisted therapy, and you need to take an exam, and you need to get CEUs. That's going to add a lot of costs. And currently, many of you are probably aware that behavioral healthcare, specialty behavioral healthcare, is one of the most difficult specialty cares to receive in the United States. Even people with really good insurance have difficulty accessing specialty care. So I try to teach our students at Columbia to think about how can we improve access while improving quality. And some ways that we could possibly be doing that is group work, when the group act itself could actually be beneficial for people, like maybe people who are like in 12-step programs, or people who all have substance use disorder, or you can think of affinity groups. You think about doing extension into community care. So how do you support a long integration process within the community outside maybe of the medical system? It could be having a peer specialist as one of the two people in the room during the psychedelic therapy sessions. But I'm pretty wary of the pay-to-play models, where the more certifications you have, the more you're thought to be a good therapist. Just because somebody can take a training program in ketamine and MDMA and 5-MeO and DMT and psilocybin, and they can put out $50,000 or $100,000 towards their training, there's really no evidence that that actually will make them a better psychedelic assisted therapist. And so I think that when we think about efforts to increase quality, we need to make sure that they actually do increase quality, that there's empirical evidence to support that. And then we really need to think of the access issues, because the risk is, and we're going to talk about this in a minute, the more expensive and inaccessible it becomes in the healthcare system, the more people will access it through the adult supervised use model, the underground model, the unregulated models. And therefore, you could have people with the highest need end up in the environments with the least amount of support. Next slide. So I like to also talk about, thinking about access strategies in the ecosystem, in the industry. There is going to be an effort to scale psychedelics to the most people. Like, how can we build as many possible clinics that will see as many people as possible? And I always try to shift the conversation to how can we think about prioritizing the people who are in the most need, and then design the system around serving them first. And the intersection of these two, the psychedelics to the most versus psychedelics to the most in need, I think of as probably including veterans, and I think of as end of life, and maybe substance use disorder, though I think that we still need a little bit more rigorous evidence on substance use disorder before I would put it into that category. Next slide. So one of the ways that Jay and I both have been involved in trying to make sure that we have a well-trained workforce. And when I say workforce, I don't just mean people who are working with psychedelics. I mean the primary care doctors. I mean any therapist that a person may see. If you think back to the regulatory pathways, currently today, many therapists say that they have patients who are going to use psychedelics in either Oregon, Colorado, Peru, Mexico, an underground setting. We need everybody who works with people in mental health and in substance use disorder to be aware of the science. They need to be aware of where it's at, where the evidence currently is. They need to be aware of the risks and the benefits. And so what we, Columbia and Penn, about 4 years ago, we piloted a faculty training program where we train faculty in psychedelic assisted therapy and psychedelics specifically. And then we provide access to curriculum for them to adapt for their own use. So the entire psychedelic therapy training program that I've created at Columbia University is available online to anybody, faculty fellows who participate in the training program through UPEP. All of my slide and lecture notes, all of my syllabi are available for them. And this is just a snapshot of universities that have participated in the 2025 cohort and the 2026 cohort. This ranges crosses discipline. In 2025, we only focused on nursing and social work. In 2026, we've brought in physicians, licensed counselors, licensed family and marriage counselors. And the goal is that if you come in and you talk to any of your providers about psychedelics, that they will be informed. And we see this as a big important effort towards harm reduction. Next slide. When you talk about harm reduction, it's good to note that psychedelics sit in a spectrum related to harms that we know of, related to other substances. And, they are not without harm to self or others, though they tend to be lower than people sometimes assume based on their Schedule I status. Next slide. And I like this slide. It's a little hard to interpret, so I'm just going to explain it to you. But this is essentially Oregon's dashboard that they put up that anybody can look at any given time. It's been estimated that 16,000 people have had psilocybin in the adult supervised use program in Oregon, most of them from out of state, most of them higher income. During that time, there's been 16 emergency services reports. There's been 3 adverse behavioral reactions. 4 of them were considered severe. 6 adverse medical reactions, 1 severe medical reaction, and 3 people reported post-section reactions after 72 hours. Next slide.
So despite the fact that psychedelics are remarkably safe, as Heidi just mentioned, relative to other substances, there are sort of 3 categories of harm reduction that we think about when we think about patient safety and ethics related to psychedelic assisted therapies. The first one is physiological safety, and obviously, the different psychedelics have different profiles when it comes to physiological safety, but cardiotoxicity is one of the ones that we look at, especially related to ibogaine. And some of the ways that that is mitigated is the ECG monitoring, specifically also during ibogaine, and favoring classical psychedelics like psilocybin and LSD, which lack some of these cardiotoxic effects that we see. Psychological safety is also another safety issue that we talk a lot about in psychedelic research. Specifically around challenging experiences during the acute dosing session. Sometimes people can feel distress, and sometimes there can be exacerbation of underlying pathology. And so that's where the pre-screening and the preparatory sessions are really important. And a lot of the clinical trials, most of the clinical trials have excluded severe comorbidities, specifically around psychotic disorders or any of the disorders that tend to be more in the realm of disorganized thinking. And the idea is that psychedelics perhaps could exacerbate disorganized thinking. So those folks are often excluded. Thorough preparation sessions to build trust and readiness for the experience, and of course, adverse event monitoring. And then vulnerability or hypersuggestibility in that neuroplastic state is something that we've talked a lot about in terms of the ethics of providing psychedelic assisted therapy. And there's a lot of emphasis on very intense ethical training for clinicians specifically around maintaining professional boundaries, not just during the acute psychedelic experience, but obviously well into the integration period, especially when patients are experiencing lots of heightened feelings of social connectedness and empathy, and that there have been instances of clinicians really crossing those boundaries with patients in ways that have really hurt the field as well as the patients. And so as we're moving toward mainstream access from where we are now, we really need to emphasize methodological rigor in our studies. So we've had a lot of small open label studies that have shown promise and have given us a lot of reasons to invest in these larger scale phase 3 trials, and using factorial designs to separate the drug effects from the psychotherapy effects. We need to standardize our outcomes, especially around substance use disorder, to look at, dosing, the adjunctive psychotherapy, and start to really allow for these more robust meta-analyses. And accessibility and equity, as Heidi very well explained, that the cost barriers of a multi-day, multi-therapist treatment model are very serious, and we really need to think about frameworks that are scalable, and make sure that we're providing high quality care beyond just the people who can already afford these very expensive treatments. And the other thing I wanted to emphasize, I'm very passionate about, peer support and peer-based approaches to some of this work. And I think what's interesting is that this is already happening. Psychedelics are already available. The majority of people who are using psychedelics are using them in what we often call underground or naturalistic, non-clinical settings. And peer groups are already organizing around their own goals in working with psychedelics. And some of these are listed here. They're at the San Francisco Psychedelic Society. Danielle Nova founded a group called Psychedelic Recovery and is already educating clinicians about how to work with their patients who want a microdose for addiction recovery. Fireside Project is a call line where you can get support for working with psychedelics, whatever your goal is in working with psychedelics. But I think just it's important to note that this information is out there. People are already using psychedelics in kind of a self-medicating way. And it's really, really important that clinicians and medical providers are educated about psychedelics so that they can talk to their patients about psychedelics in an informed and non-judgmental way. So thank you so much. Thanks for listening, and we're really excited to answer any questions that you may have. I know that was a lot of information.
If we have any questions, I'll just look through the list. I don't see anybody's hand up at the moment.
I'll start. I have a question.
Okay, good. Then I'll ask a question too if nobody else asks questions. Go ahead.
Really, I want to thank you, Heidi and Jay. Wonderful presentation. Really scientifically so powerful. I truly appreciate it. I was thinking, is there evidence that there is gender differences? In my knowledge, that there is evidence, but it looks like uneven. The clearest differences that I'm aware of in terms of gender is the MDMA, that is difference between men and women. So I wonder if through your research or literature, you have any thoughts about this issue?
I'll jump in, and then eager to hear Jay's thoughts. We believe that there are sex differences, particularly related to hormones. So depending on where a woman might be in her menstrual cycle, or particularly for women who are perimenopause or menopause, it does seem to have an effect on dosing. And there is some evidence that typically psychedelics have been dosed at everybody gets the same amount. That's not true for ketamine, but it is true for like psilocybin and MDMA, and that weight might matter as well. But I'll ask Jay to weigh in on any of the more clinical or psychological elements that the research has shown.
You just covered it brilliantly. I think there's a lot more research to be done in this area, specifically around hormones, but also around the different psychological approaches and what might work better. But I think it's a really good question, and we need more research.
Thank you.
Uh, Dr. Lieberman.
Yes, can you hear me okay?
Yep.
Yes.
Thank you for those excellent talks. And I agree that with Heidi, with the idea of looking at a more functional general measure would be preferable than confining the assessment of improvement to a given indication. Um, However, I've been watching this develop over the years, and actually I'm old enough to remember the first iteration back in the 60s and 70s. And I'm very concerned about the fact that the field is moving ahead, meaning the commercial sector of the field, without sufficient evidence and without having defined, what the appropriate therapeutic targets are. And so one question is, I wonder how the panelists feel about the broadening of the term psychedelic to include drugs that have a very different pharmacology and subjective clinical effects, meaning the dissociatives and the empathogens when they're not classical psychedelics. And it's consequential not just for the fact that they work differently in terms of their potential therapeutic, but also they have different risk profiles. And then the second issue is typically when there's a psychosocial component to any treatment, whether it's with pharmacology or otherwise, there's a standardization, a manual that's developed and reliability established. And so that there's a standardization and then a dismantling study afterwards that is to try and separate out the drug effects from the treatment effect. And I don't see this kind of rigor built into the designs of any of the studies that are being pursued in terms of FDA approval.
Well, I'll start working backwards. It's because my memory works that way. I think that, we should differentiate therapy that happens during the psychedelic acute session and therapy that might happen after the session during integration. It's not clear that much therapy can happen during the psychedelic session. Perhaps with MDMA, I think out of all of the molecules, MDMA is the most conducive for therapy. But what Jay brought up about recognizing that people are in a non-ordinary state of consciousness and that they're inherently vulnerable, I think should make us tread carefully in directive approaches. Whether directive approaches of therapy, which are often ones that we use, are appropriate when somebody is in a non-ordinary state of consciousness. When you think of the other psychedelics, the classical psychedelics, it's probably impossible to do therapy during the psychedelic session. And really what you're talking about is what are you going to do after the psychedelic assisted therapy? And how do you support that? And I think that in those settings, we can look at evidence-based approaches and see which ones might be most or more useful, and we might have to create some new ones. But it seems, if you've ever been with somebody in who has done an LSD experience, for example, the idea of working through a linear module evidence-based approach would not make any sense, and I don't think it would even be feasible. But you could ask yourself, could I work with somebody through a module linear approach in integration? Then sure. Currently, the psychedelic community, after the denial of MDMA by the FDA because of how they felt like the therapy was so intensive and yet so inarticulated, most of the clinical trials has done the opposite. They've completely withdrawn therapy from the clinical trials, and they're providing only the basic psychological support, which I think actually comes perhaps with a risk of harm to people during those sessions, to have people just watching them but not intervening when they're in distress. And I worry that it's going to lead to a model like we have with ketamine, which is highly medicalized. And in a lot of instances, including, where we provide it here at Columbia, it is not accompanied with therapy at all. So it's like interesting how the clinical trial and the rigor we're trying to get in the clinical trial may set up this artifact in implementation where we say, okay, well, the clinical trials didn't have any therapy, so we're not going to have any therapy. And I think that that would be a very bad outcome for efficacy and durability. And based on what we know about the period of time of neuroplasticity following the psychedelic experience. Um, at the same time, in the therapy program that I created at Columbia, we hold very lightly what is going to be the right therapeutic approach because it has not been a variable that's been manipulated yet. And so I don't think that we could say we know that people like, for example, in the MDMA clinical trial control group, that they did really well in the control group. So we know that that therapy was successful, but we don't know that any other therapy would be more or less successful. And so we need that kind of work to happen before we really, I think, know how to address it. But what you suggest is like, are we getting ahead of our skis? I think in some ways, yes. And in some ways, no, because the Controlled Substance Act put such a damper on this work for so long that is why the states are outpacing the FDA. And that may cause problems, right? The people have become so impatient for psychedelic assisted therapy that they have created ballot measures to pass legal psychedelic assisted therapy in their state, like we have in Oregon and Colorado and New Mexico. And we're going to see more of that happening. And so, in some ways, you need the FDA process to speed up a little bit. And if opening up NIH funding for that rigorous research, so it's not just coming from philanthropists, I think would be both a step in the right direction towards rigor, but would also be a step in the right direction towards building the evidence that you're talking about.
So if I could just make one more comment. With cannabis, we did that. The state legislatures yielded to public pressure, and it turned out that the therapeutic measures or therapy. Well, Meg Haney's on the and Ned Nunez is there. They know far more than I do, but that turned out to be a Trojan horse, the medical uses.
And I think that there are probably people who would like to see psychedelics be a Trojan horse for, being able to sell it right next to cannabis in the stores. And so hopefully we can really get some good research to show about, why we might want to see that in a clinical setting.
All right, so one last thing. What do you feel about sensorily deprived administration of psychedelics versus open to ambient stimuli?
Wow, that is what do you think, Jay?
It sounds like an intense experience with a sensory deprivation on psychedelics. That would be an interesting research study. I'd be curious what the research question would be.
Which is more effective?
Yeah, you should do that study. I would follow it avidly. I don't know. I think people say that the set and setting, the music that people listen to, the closing the eye shades so that, that's a step towards what you're talking about, decreasing visual stimulation. But most people feel like the music is really important in helping them have a sense of safety and kind of taking them along a journey. But I think all of that research is really important and interesting, and I would love to see it.
Ned?
Thank you.
Thank you, Ned.
There, can you hear me?
Yep.
Yeah, well,
Yes.
thank you for those wonderful presentations. It's really terrific and to hear about your work. It's sort of a follow-up to Jeff's question. Is there a treatment manual for the not therapy during the psychedelic experience, but is there a treatment manual for the preparatory period and the post experience integration period? And what's it like? How does it resemble evidence-based behavioral treatments that we currently have, motivational interviewing and so forth? And is there controversy or ideas in the field about what would work better? I guess put another way, if you were going to do a study of two different therapeutic approaches for the preparation and the integration, what would it be?
That's a great question. For me, there are a number of manuals that have been published. There was one that was just published It's called MIPS, and I'm forgetting what it stands for, but it would be for MDMA assisted therapy. And it's really has like humanistic origins. So like Carl Rogers approaches. And what I think all of the therapeutic approaches tend to have in common is that they're not directive. And primarily because what I said, which is that people are very suggestible, and there are some really serious ethical questions about what it means to start using directive approaches from a therapeutic perspective on people who are innately and inherently more suggestible at that time. Like, sure, it would be great if they're saying what you think that they should be told, but in general, all of the therapists involved in the trial and the people who worked in the research, even in the 50s and 60s, agree that the client should really allow the therapist should really allow the client to direct, and that the therapist should not try to be interpretive.
So is it a goal setting kind of emphasis where you elicit the person's goals? Is that an idea?
Yeah, I think that a lot of the tools of psychotherapy are brought into place, including like the establishment of the relationship, the ritual of setting goals, the rituals of measuring your progress to goals. I think that typically you're trying to see if they had what their experience was like, if they had any insights, if they're thinking differently about anything, if it's leading to any behavior change that they may want to make. But I imagine over time, right now, in the clinical trials of the last several years and the ones that we probably see get FDA approval, they're really not doing therapy. And so we're going to have to wait until there is that funding to try different empirical approaches. Evidence-based approaches would be a good place to start.
And is there controversy in the field? Like, again, my question, if is there a burning question? Are there two different
I would say one
approaches you would test if
controversy,
you
I
could?
would say one controversy is an exposure therapy. So there are people who think that that exposure therapy should be used when you have that limbic deactivation, that the exposure therapy is an evidence-based approach. And there are other people who say, no, that is unethical. You should not be doing that. That would be a controversy that I would say. And it's an empirical question, and people are testing it.
And I would say, I would add too that, there are some, there has been some pressure on the field in general to start identifying some therapeutic modalities that are kind of leading the way in terms of how to work with psychedelics. Internal family systems is one of those kind of interesting, questions, but very, very much very prominent in the field. We did a pilot study of ketamine in a group therapy setting using cognitive processing therapy and adapting it to the group. And the idea being that when people are in that neuroplastic window, it can be useful to provide tools for people to work through some of the psychological and behavioral issues that are part of the goals that they had for themselves in starting the therapy. So I do think that there is some movement, and there are some modalities that lend themselves to psychedelic assisted therapy. But like Heidi said, I think that the main issue is, how directive, and certainly not during the session. And I think the exposure therapy specifically around MDMA, the other psychedelics, I think people would largely agree that exposure therapy is completely inappropriate. But MDMA and the reduced activity in the amygdala, and how people may be being able to approach traumatic content in ways that would normally be flooding and overwhelming, is maybe lessened with MDMA.
And I would add that there's interest in somatic approaches. One of the things that's really interesting about psychedelics that I don't think has been well studied yet is that people will say, well, I knew something my whole life. Like, I always knew that the abuse I experienced as a child wasn't my fault, or I knew that the violence that I committed in the military was part of my job. Like, I knew that, but I couldn't feel it in my body. Like, my body, I still held it as if it wasn't true. And one of the things that happens after psychedelic experiences is people feel that self-compassion. They feel that knowledge that it's not their fault for the first time ever. And how do we measure that? I don't know how we measure that. I think we're going to have to come up with new ways of thinking about it. But there, people who study consciousness, and this comes up with the talk of AI as well. AI can think, but AI can't feel. And we can think, but we also feel. And something that changes a story that you have that you feel in your body could be very, very powerful. And I don't know how we measure that, but people have found that somatic approaches, so helping people recognize and identify what they're feeling in their body when they're talking about their experiences, that tends to be effective. And so that's something that needs to be studied more too.
Yeah. Jake?
Can you hear me?
Yep.
Yes.
All right. First, I just wanted to thank you both for such an excellent presentation. I particularly like the back and forth. It was really well put together. I've got two questions. So first, if there is an indication for a particular psychedelic medicine, do you see that kind of like being prescribed, or is it more of like a voluntary thing that kind of we're seeing with the veteran groups? And then the second question is, I was wondering if Dr. Allen, if you could, kind of walk us through how you're teaching the Columbia students to conduct the psychedelic assisted therapy.
So Jay, do you want to go first and I'll answer the second question?
I would love to hear your thought on the prescription. I think that's an access question.
Yeah, I mean, I think that prescribers are probably not going to be doing the therapy because that would be very expensive if they sit out with people for 8 hours. I think it will be accessible by prescription. It depends on the rescheduling, whether people will be able to go and pick it up at a pharmacy. I've heard rumors that they think that psilocybin might be Schedule 4, which I find kind of shocking. But yes, I think that it will be by prescription. I think we'll see it in outpatient clinics like oncology clinics, palliative care clinics. I think we'll see it in VA clinics where people will come in and get it. And then I think people who can't access it through through the medical model will probably try to access it through these state regulated models. And so I think that there's going to continue to be a parallel track. I don't think that that's going away. I hope that answers your question. I wasn't sure if I totally understood.
Now that answers it. Thank you.
Okay. And how do we approach therapy? Well, I don't teach either of the therapy classes because I have not been a clinician for a long time. But we have 2 semester-long classes where we go over the science. We talk about the history. We talk about the cultural embeddedness of some of these molecules. We go through each molecule one by one so that they have a really good understanding of it and the research associated with it. We talk about things about like access and equity. We talk about complementary therapies that people who are working in the field right now say seem to be effective. And then I prepare them to be good consumers of research and to be ethical practitioners. We talk about the competencies that people have identified for a psychedelic assisted therapy and how that intersects with the competencies of social work so that social workers are practicing within their scope of practice and within their lane. And then the second series is another 2 classes over the semester, and they're talking about prep, screening, prep, working with people during the medicine sessions and integration activities. And they are doing case presentations from their practicums, which are 600 hours. And they're doing role plays. So they're really trying to practice as much as possible. So they're getting about 120 hours worth of coursework. They have probably 50 hours worth of readings outside of class, and then they have the 600-hour practicum. And we're the only program in the country, or as far as I know, the world, that has something like this. And the reason that I created it is that programs like ours cost about $18,000 for postgraduate education. And you think about social workers, they don't make that much money. And if we're asking them to graduate and then go on and take another $18,000 or $20,000 in education, and if they have to take separate licensures and they have to do separate supervision, they are not going to be able to participate in insurance. And certainly they won't be willing to participate in the Medicaid program, which is what I'm passionate about. So I really try to socialize with them their obligation that if, hey, I'm giving this program to you with no additional charge to your MSW program, and I ask that you pay it forward by participating in insurance and particularly by participating in Medicaid.
This is Jeffrey Lieberman. Can I ask another question?
Yeah, go ahead, Jeff.
So what occurred in the 60s and 70s was the idea that, first of all, I'm passionately supportive of the need to make full use of psychedelic drugs and study them in terms of how they can be best used. But at the same time, I'm somehow a slave to, being the wet blanket, scientifically speaking, in terms of rigor to know what it is we're doing so we don't make the same mistake again. But and I had a debate on an NPR program with Rick Doblin about this, who thought it was really going to be the cure to the evils of humankind, and I think there's something to that. Meaning, there's a salutary effect that goes beyond treating psychopathology.
Mhm.
So, how do we navigate between the two in terms of how it can best be used responsibly, and both for therapeutic purposes and even without the need for having to justify its use by some therapeutic indication?
Yeah, I think that's where the studying the functional impairment could be helpful. If you could identify that people, experience times in their life where their mental health starts to deteriorate, but they're not yet meeting any clinical indication, and you can demonstrate that it could help prevent, somebody crossing that threshold, I think we may be able to see these kind of treatments offered in the mental health system for things like adjustment disorder, NOS, like when you've lost a parent or lost a job, when you're going through a divorce. I mean, there's all sorts of times in your life that people need more support, but they don't meet the criteria that we have in the DSM-5 TR. And also, I'm not opposed to the state supervised use programs. I myself went to Oregon to try it out. I have never been more thoroughly assessed than I was through their regulated system, and I had a really beautiful experience. And I think that those programs, as long as they continue to be safe, as long as they can continue to be well regulated, the problem is they're very expensive. And so there may be people that the only affordable way to get access to psychedelics is through their health insurance. And there is the risk of if it continues to be expensive in all of the models that we create, where we try to have a lot of safety and accountability built in, then people will be driven to less safe models. And that is of concern, though you definitely see, even like in festival scenes, you see a really strong organized effort to have people there who are providing harm reduction services. And so I hope to continue to see those develop over the years too.
Okay, well, we're gonna have to. Do you want to have the last word, Jay? Go ahead, because we're gonna stop.
I just wanted to piggyback on what Heidi was just saying, is that I do think that as researchers and scientists, we do have an obligation to also look at these naturalistic uses, because psychedelics are already in our society. People are using them with peer support. How do we optimize benefits for people and minimize risks in contexts in which psychedelics are already being used?
Well said, Jay.
Yeah, this was a wonderful presentation. I had questions, but I didn't get to ask them. I'll find you both afterwards. Thank you so much, and it really was a great presentation, really thought-provoking.
Thanks for having us. Really appreciate being here.
Thank you so much.